In this lecture, we will discuss right coronary artery occlusion, including the regions of the heart potentially affected and their corresponding EKG features. The right coronary artery, or RCA, supplies the entire right ventricle via the right marginal artery. It gives off the posterior descending artery, or PDA, which supplies the inferior wall of the left ventricle in about 90% of individuals, those with that right dominant system. If you recall, the PDA arising from the RCA is what we said is the right dominant system, while the PDA arising from the left circumflex coronary artery is referred to as the left dominant system. And then if we have a PDA that's supplied by both the RCA and the left circumflex artery, we call this a codominant system. It's also important to be aware that the right dominant system, in this case, the RCA will also and sometimes supply the AV node and gives off branches that supply the SA node, the sinus node, in more than half of individuals. Furthermore, the RCA supplies the posterior third of the interventricular septum in the inferior left ventricle, by means of the PDA. It also gives rise to branches after the right marginal artery that may supply the posterior wall. For our purposes, you should think of the RCA as supplying the inferior and posterior walls as well as the right ventricle. So let's look at our right coronary artery. So again, here's our aorta, and then our RCA, right coronary artery, coming off that right aortic bulb. And coming off there, you can see we have this right nodal artery that's supplying the SA node. You have this right atrial artery that's also supplying the right atrium. You have one that's supplying the right ventricle. And again, we're seeing that it's supplying sometimes the sinus node in more than half the patients, the AV node. Mainly the right ventricle, that's the most anterior portion of the heart that we have coming off, as well as the inferior left ventricle, in the posterior 1/3 of the interventricular septum in most individuals, So as the RCA comes around, it then gives off this PDA. So these here give rise and supply the AV node, but the PDA will supply the inferior left ventricle wall as well as the posterior 1/3 of the interventricular septum. Now let's take a look at what happens when the RCA is occluded. So in individuals with right dominance, occlusion of the RCA causes inferior wall MI. If the occlusion occurs more proximally, it may also affect the blood supply to the right ventricle and cause a right ventricular MI. And we will also see that occlusion of the right coronary artery may cause a posterior wall MI, if it supplies that area. So first, let's look at the inferior wall MI. In this case, we will see ST elevation in the inferior leads 2, 3, and AVF, with it being greatest in lead 3. Most cases will also show a reciprocal ST depression in leads 1 and AVL. So what we're saying here is the inferior wall MI. So imagine the inferior portion of the heart down here being affected. So what are our inferior leads? Here's 2, 3, and AVF, and because it's mostly on the right side, it's going to see and show up more, here in this region. So 3 often shows the most ST elevation in that leads, The reciprocal leads, those mirror images that will see the ST depression, are leads 1 and AVL, These high lateral leads that are pretty much showing this region here. So they're pretty much opposite of that, and that's why we see reciprocal ST depression in those leads. So again, here's our 12 lead EKG. We're looking at our inferior leads. So here's 2, 3, and AVF. These leads, we're going to see the ST elevation, then lead 1, lead AVL, we will see ST depression in these leads, That's the reciprocal changes. They're secondary ST depression from the primary ST elevation, So that's an inferior wall MI. Now let's look at an inferior and posterior MI, Sometimes called a posterobasal MI. This means we have both the inferior and posterior walls supplied by the right coronary artery that are affected. In such cases, we will see ST elevation in those inferior leads, so 2, 3, and AVF, as well as in the posterior leads, V7, V8, and V9. Reciprocal ST depression can be seen in leads 1 and AVL, as well as V1, V2, and V3. So again, let's just erase this here. Now we're saying that we have a posterior wall MI, as well as an inferior wall MI. So the inferior wall over here being affected. So our inferior leads 2, 3, and AVF, we'll see ST elevation. So this is these leads here. And then we also said in our posterior leads, the posterior wall will show us in V7 through V9. Okay, so we see ST elevation in these leads. Okay, now similarly to the inferior wall infarct, we will see reciprocal changes in 1 and AVL, okay, because of the inferior portion. Okay, so we're seeing opposite changes in these leads, so that's ST depression, reciprocal changes. And we also said because of the posterior wall MI, we're going to see reciprocal changes in leads V1 through V3, okay, because they're pretty much mirror images of those posterior leads V7 through V9. So again, reciprocal ST depression in leads V1 through V3, okay, so these leads here, we would see ST depression, and the same thing in these leads. All right, so notice with the standard 12 lead EKG, we're not seeing ST elevation in that posterior infarct. We have to get those posterior leads V7, V8, and 9 to see that those ST elevation changes. Okay. So it's also not uncommon to see unusually tall R waves and positive T waves in leads V1 through V3 during these posterior wall MIs. These are pretty much reciprocal changes to the posterior Q waves and T wave inversions. Okay, so remember, with ST elevation, eventually you get Q waves, the pathological Q waves that form, as well as T wave inversion, okay, that may persist for a while. Now, if you have that in the inferior leads, you're also going to get it in the posterior leads, okay? And what are the opposite changes of Q wave inversion, or Q wave, pathological Q waves and T wave inversion? Well, think about it, okay? So imagine you have these pathological Q waves, which are these ones here, and then you have T wave inversion. The opposite would be large R waves, okay, here, as well as upright T waves. And that's what you can see in those right precordial leads V1 through V3. Okay, so they're pretty much the reciprocal changes of the pathological Q waves and the T wave inversions in those posterior leads. All right, so let's move on to a right ventricle infarct, okay? But before we go any further, I need to make something clear. None of the standard leads on the 12-lead EKG is sufficient to capture the injury currents from the right ventricle. And there's a common misunderstanding that you may hear among your colleagues. That misunderstanding is that leads V1 and V2 record right ventricular activity. However, this is not true. Leads V1 and V2 primarily view the electrical activity of the interventricular septum. So while these leads are looking for and can give us atrial abnormalities or even ventricular hypertrophy, they truly sit over the interventricular septum and shouldn't be used to diagnose a right ventricular infarct. Okay, so let's just erase this here so we can clear this up and you can see through all this writing. Okay, so V1 and V2, they're pretty much sitting here, the septal, right? They're pretty much supplying this interventricular septum, and that's what those leads do, V1 and V2, okay? So when occlusion of the right coronary artery affects both the inferior wall and the right ventricle, we may see ST elevation in leads V1 and V2, with it being greater in V1, okay, because it's closer to the right ventricle. But to confirm a right ventricular infarct, you really need to get a view from the right-sided chest leads, okay? You would connect V3R, V4R, V5R, and V6R, and these leads should display ST elevation, okay? So because imagine the right ventricle sitting here, okay, in this anterior portion. So we can see changes in V1 and V2. It'll be greater in V1, but really in order to get a true idea, we need to look at these leads, these right-sided leads, V3R until V6R, okay? So that will give us ST elevation in those leads. All right, and we said if it's in V1 and V2, it will be greater in V1 compared to V2, okay, because it's V1's closer and sitting more in closer proximity to that right ventricle. Now, another thing to note is that the ST elevations in right ventricular infarcts will have a shorter duration than an infarct affecting the left ventricle. And this is because the right ventricular wall is much thinner than the left ventricular wall, and therefore the infarction will occur much faster. And one last clinical point. Why is it important to confirm a right ventricular MI? Well, it's because our management will actually change. These patients are now preload dependent, so giving them fluids would actually be beneficial, whereas this could only exacerbate the situation in the setting of a left ventricular MI. Therefore, you should place the right-sided leads if you suspect a right ventricular infarct. All right. That's pretty tough stuff, so great job if you're able to follow along. Let's review this before we end here. So again, the right coronary artery here supplies the right ventricle, sometimes the sinus node, the AV node, as well as the posterior wall. In right dominant individuals, it gives off that PDA. That PDA supplies the inferior left ventricular wall as well as the posterior 1/3 of the interventricular septum. Now we talked about the right coronary artery occlusion. Okay, so again, notice this occluded artery there in black. That's what that's showing there. So that right coronary artery is occluded. And in this case, we can have an inferior wall MI. Okay. We can also have right ventricular involvement if it's more proximal. Okay. So notice this. Let's just clear this up here. Okay. Notice that this artery here is supplying the right ventricle, so if it's coming proximal, like in this place, we can also have right ventricular involvement, okay? And then we said we can also have posterior involvement, but realize that it's the inferior wall that's pretty much involved in all of these that right coronary artery is supplying. So with an inferior infarct, remember we see ST elevation in the inferior leads, 2, 3, and AVF, but it'll be greatest in lead 3, okay? Our right ventricle is here, okay? So it'll be greatest in lead 3, and we'll see reciprocal changes in 1 and AVL, okay? With a posterobasal, where we have an inferior and posterior involvement. In this case, again, we'll have those inferior leads showing ST elevation and reciprocal changes in 1 and AVL. But now with the posterior involvement, we're going to see ST elevation in the posterior leads, V7 through V9, okay? As well as reciprocal changes in leads V1 and V3. Okay, so we'll see reciprocal ST depression in V1 through V3, and 1 in AVL, ST elevation, V7 through V9, and the inferior leads 2, 3 in AVF. Okay, and we also mentioned the reciprocal changes where we can have those tall R waves and the positive T waves in V1 through V3. Okay, these are pretty much reciprocal changes of the pathological Q waves and the T wave inversions that we would see in those posterior leads. If we have an inferior involvement as well as the right ventricle, so that proximal occlusion as we mentioned here, in this case we may see V1 and V2 showing ST elevation. So again, these leads here, let's just erase this again. So V1 and V2 may show ST elevation. If there is ST elevation, it'll be greater in V1 compared to V2. And then we also want to confirm this by getting those right-sided leads, okay? Getting these here, V3R until V6R, okay? To help us confirm that we actually have a right ventricular infarct. Again, we'll see ST elevation in those leads there, all right? And again, this is really important because our management will change. And remember, the ST elevation duration, so how long we actually see ST elevation in a right ventricular infarct is shorter, okay, because of that thinner right ventricular wall compared to the left ventricle, and therefore this will be a faster infarct, okay, and we'll see the changes much sooner, okay. Well, that's the end of this lecture. We discussed right coronary artery occlusion, including the regions of the heart potentially affected and their corresponding EKG features. I hope you learned something.